Дорогие коллеги, добрый вечер. Мы рады, что вы подключились к нам или вы смотрите в записи наше совместное подключение вместе с Европейской школой онкологии. Сегодня мы будем говорить о фармакологии противоопухолевых препаратов.
Дорогие коллеги, добрый вечер. Это последнее подключение от Европейской школы онкологии в этом году. Те из вас, кто слушал предыдущие лекции, молодцы, и вас ничто не испугало, и вы готовы прослушать вторую часть. Это и не самое простое для восприятия, но тем не менее полезной информации.
Тем, кто не слышал и присоединился впервые, на самом деле это тема, которую можно начинать изучать с любого места. Поэтому welcome, мы рады вас приветствовать. Единственная ремарка, которую мы хотели сделать в начале заседания, это о том, что мы рады и открыты вашим предложениям по нашим дальнейшим темам заседаний. Да, мы знаем, что большой интерес вызвало заседание, когда Галина Сергеевна рассказывала о правильности написания научных работ. То есть у нас есть предложение, может быть, вам интересно будет послушать, как правильно сделать презентацию, как стать успешным, как использовать различные гранты, как... Что еще, Галина Сергеевна, можно...
Выстроить свой карьерный путь.
Да.
Что вас интересует?
Вам интересно? Может быть, вам интересна какая-то, например, там, Cancer Basic, да, основы рака, не знаю, противоопухолевого лечения. То есть мы открыты к вашим предложениям, будем рады, если вы напишите в комментариях под этой трансляцией, либо нашей группе на Фейсбуке, Инстаграм, Галина Киреева, МД Харченко. Мы всегда открыты к вашим предложениям, потому что на самом деле это все делается для вас, и ваша обратная связь для нас самая важная. Поэтому ждем ваших предложений. На ноябрь принимаем заявки по тематикам, будем выбирать самые интересные и транслировать для вас.
А теперь... слушаем профессора Сессу,
которая, между прочим, на ESMO 2019 была признана женщиной года. Смотрим на профессора Сессу, берем с нее пример и получаем новые знания.
Wrong signals and wrong repair system bringing to abnormal DNA. And this is the mechanism which might be responsible for the development of tumors in patients with the hereditary syndrome BRCA. So the point is that one important mechanism where the alkylating agents are active is the induction of double-strand breaks, because the single-strand breaks can be repaired. Double-strand breaks, no. So the point is this, how we can induce the double-strand breaks. This is something we are going to discuss. Now, let's start with the alkylating agents. When we say alkylating agents, we refer to the process of alkylation, which means the transfer of an alkyl group, which is this one, which is an alkane with only one single bond missing and one H, from one molecule to another. And according to this activity, we can distinguish different classes of alkylating agents. We know that they can be very different. They can be active or they can be prodrug. They need some enzymatic activation or chemical breakdown, spontaneous degradation. The important point is that the active moiety which is formed is going to alkylate on the DNA in some particular position, which are very specific for each alkylating groups. And the most frequent one is the alkylation of N7 on guanine, which with inhibition of the DNA replication. And then we can have a bifunctional alkylating agent, which means that this alkylation happens on two different strands of the DNA. So we can have interstrand cross-links, and in this case, it's not possible the replication because there's a block of the two different strands of the DNA, or we can have intrastrand cross-links. In both cases, we have adults that for the interstrand, the adults are on the two different helix, and therefore they are called interstrand cross-links. which are really the lethal one for the cells. Now, the point is that the non-alkylating component, so the moiety which is linked to the functional group we've seen before, it's going to affect the pharmacokinetics, the biodistribution, and the toxicities. So then we revise the common features of the toxicity of alkylating agents, and then the specific toxicities of the different groups, because that's something relevant for clinical practice, because you should know how to manage them. So we have the difference in terms of potency, in terms of toxicity, and also disease selectivity. And this is the reason why one alkylating compound is very active in one particular tumor type, but it's not active in the other one. And we have 5 classes of classical alkylating agents. And the first one, the most used, is the nitrogen masters, which is the oldest class. And these are the compounds which are included. You can see that they have a very different spectrum of activity and toxicity, but they pertain to the same class. And the nitrogen masters are very effective. And the common structure is the bis-chloroethyl group, which then, after the activation, cyclizes with the ammonium moiety, which is the active component, or the aziridine rings, which is responsible for the formation of the interstrand crosslinks. And in particular, all these compounds, they alkylate the N7 of guanine. So it's important to remember, because once we have an alkylating agent or mechanism of alkylation on a different target, that's something which can be used to overcome the resistance to this particular class of agents. The other important class are the aziridine, ethylenimine, and they have 3 aziridine rings. They are less reactive compounds than the nitrogen masters, and in this particular category, which is still used with very specific indication, or perhaps in the high-dose treatment, is thiophepa, because the alpha-amine is not used any longer. And again, there's an alkylation on the nucleophilic sites on DNA, RNA, and protein. The other important class are the nitrosoureas, and the nitrosoureas, they rapidly decompose into aqueous solution. These compounds are used in brain tumors, and we'll see later on why. And what is important for these classes, as well for the triazine compound, is that there's an inverse correlation between the anti-tumor activity and the expression in the tumor tissue of the enzymes, the O6 methyltransferase, which is responsible of the repair of the damage, because that's responsible to cleavage, again, the first adduct which has been formed. So usually with the nitrosoureas, there's a 2-step process, and they form bifunctional adducts. But these enzymes, which might be present with different expression in the different tumors of the same histological type, is able to remove the first adduct. And therefore, if the first adduct is removed, the second one cannot be linked. And therefore, there's a repair of DNA, and the compound, they lose their anti-tumor activity. And this is why the expression of these enzymes in brain disease might be important for the anti-tumor activity of nitrosoureas, and mostly for temozolomide. And actually for the triazenes, which are another class of the classical alkylating agents, they have a chemical decomposition. So the nitrogen master, for example, cyclophosphamide, they are prodrugs, and they need an activation. this compound, the carbazine and temozolomide, they go into a chemical decomposition. It's a spontaneously reaction, and they form highly reactive ions, which are responsible of the DNA alkylation. So the carbazine, which is a DTIC, the drug used in melanoma, is similar to temozolomide, which is Temodal, which is used in glioblastoma and brain disease. So it's interesting to see that the structure is the same, but the particular anti-tumor activity is different. Then we have the...
Cristiana, maybe
Yeah.
maybe we can mention additionally the MGMT status that plays a certain role for glioblastoma.
Yeah, do you want to comment on that? Because that's really an important issue.
Yeah, I think that's a success story that one has seen that glioblastoma tumors that have a methylated MGMT enzyme, they respond much more favorable to temozolomide.
Right.
I mean, it has not broadly been implemented into the clinic, but still is I think a nice example that at least for this chemotherapy there is a biomarker.
Exactly. Yeah, this is really important also because that's something which was not observed in the preclinical models because when the compound was studied in animals, there was a really high anti-tumor activity because the content of the enzymes is lower than in humans. And in humans, the activity was not so good at the beginning. And only once there were translational studies showing the different content of the enzymes, it was possible to modulate and understand that there's a factor affecting the anti-tumor activity. So this is really a nice example of, I think, of translational research and clinical pharmacology. Thank you very much, Markus. And then as regards busulfan, the indication is very limited. As you can see, it's a symmetrical structure with the two alkyl sites, and again there's an alkylation of guanine with monoadducts followed by biadducts. And then we have the non-classical alkylating agents, procarbazine, and mostly the platinum compounds. That I think platinum are so important that we are going to revise them separately. So the point is that overall, we should remember that there are common features of the PK, and I think, Markus, is important that perhaps once we have gone through the alkylating agents, you briefly summarize the PK. We have a short terminal half-life. We have a high reactivity. There could be some enzymatic activating system, like the one for cyclophosphamide, for which the liver function is important, or we can have a spontaneous degradation. And what I think it's important are the common features of the toxicity, because it's a steep dose response curve. So remember, higher is the dose, higher might be the anti-tumor activity, but also higher is the toxicity. And the toxicity is mostly myelosuppression, and in the majority of the cases is neutropenia, with a different time of nadir and different time of recovery, which is important to know. And then the amenorrhea and the azoospermia, which is also dependent on the age of the person and on the duration of treatment. And also it's important to remember the teratogenic and the carcinogenic effect, which is something which was known at the beginning, and then it appeared only later on, and we revise it because that changed completely the clinical practice. So I think the point is that please remember that you can ask questions and send comments and anytime, and Markus is collecting them so that we can discuss all the points at the end of my presentation. Now, let's go quickly to the different pharmacokinetics and toxicity. I think the melphalan is mostly given orally. It's given daily for 5 days a week for 4 weeks. So it's important to leave these 2 days without the drug. The bioavailability is variable, and it can be taken once a day fasting. The beta half-life is 1.5 hours, and what is important to remember, in my opinion, is that the myelosuppression appears late. It's not so early as cyclophosphamide. Usually appears after 3 weeks. There's a recovery after 6 weeks, and I think the point is that sometimes the treatment can be repeated every 6 weeks because of the delayed recovery. But it's important to wait for the recovery. Otherwise, there's accumulation of the toxicity. And also another characteristics of melphalan is that thrombocytopenia, mostly after high dose, and thrombocytopenia could be quite cumbersome. When we use it as high dose, and it was used in the past for breast cancer, but is still used today for some high dose regimen because that's easy to use. It's important to have dehydration, but also it's important to remember that the kidney function is important, and therefore it's important to adapt the dose if the creatinine clearance is decreased. And that's the one which was responsible of secondary leukemia. So these are the leukemia which were observed in ovarian cancer patients when they were still receiving maintenance treatment for example, 12 months with melphalan, which was quite common in the past, before the start of the cisplatin and the new drugs, as well after some high-dose treatment. So I think melphalan is definitely more difficult to use than cyclophosphamide, and there are no clearly evident situations where it can be better or most preferably used. Cyclophosphamide, in my opinion, is the most frequently used alkylating agent, is very versatile and friendly user, can be given orally, daily, continuous, and you can adapt the dose and the duration of the treatment. So remember that the neutropenia appears after 2 weeks, so it's important to focus on that period and have a hematological count at that point, and also it's important to remember it when you put it in combination, because very often it's used in combination, mostly with anthracycline. So keep an eye on that. That's the crucial period, and there's a recovery in 2 weeks. So the usual regimen with cyclophosphamide, when used in combination and you mostly use IV, is every 2 weeks. But check to 14 days after the treatment. With the oral administration, there's some mild alopecia, there could be some diarrhea, and there's the problem of the hemorrhagic cystitis, mostly with the high dose, and there could be some inappropriate excretion of antidiuretic hormone with low sodium, and perhaps it's something which could be discussed because it's not so rare as it was thought, and there could be some cardiotoxicity. With the IV high dose, which is used in combination, it's important to have dehydration and the mesna. And it's the same mechanism than with ifosfamide we are going to revise. So that's important to prepare properly the patients. Good hydration, good orally and IV, and mesna, following the same rules we'll see for ifosfamide. The metabolic activation is the liver, and I'd like to remind it because there was the use of intraperitoneal cyclophosphamide in ovarian cancer, which was meaningless because the cyclophosphamide needs a metabolic activation in the liver because that's a prodrug. And the same if there's a complete hepatic impairment. Well, there's not increased toxicity, but it's likely the activation won't be so good. So that's important for the use. And then it's the point of ifosfamide, for which the indications are limited. That's mostly used in the sarcoma, and it's used in some scheduling cervical cancer for second line. It's not used in ovarian cancer, and it's used in some regimens for the recurrent testicular cancer. So the point is that ifosfamide is given IV, and always you should give the mesna before as well after. And why it should be done? Because that's through the metabolic deactivation, there's the production of a toxic catabolite, which is acrolein, and acrolein is eliminated with the urine, and through the kidney, and then through the urine, and it's very it's a toxic compound for the bladder and mucosa. So the point is that it's important to hydrate the patients to increase the diuresis, to decrease the concentration of acrolein, and also to add mesna. And mesna acts as a regional detoxificant, because mesna as well is a compound with very rich on thiol groups as H, and these thiol groups have a detoxicant effect on acrolein because they stick to acrolein, and mesna is not reabsorbed. So the point is that it's excreted in the urine. There's no potential antagonistic effect on the anti-tumor activity because it's not reabsorbed, but has a very short half-life, and therefore it should be given with repeated doses. And the doses should be calculated according to the total dose of ifosfamide. So if you want to use IV mesna, which I think is the safest one, the dose should be 60% of the total dose of ifo. And you should give 20% of the total dose over 3 subsequent dosing. The first one is done at the baseline so that they go together through the urine, but then the other 2 are given respectively 4 hours and 8 hours after the ifo infusion, because the half-life is very short and the half-life of ifo is longer, and therefore you need to cover the excretion of acrolein during this period. So usually you can give ifo as 3 hours daily for 3 consecutive days, or a 24-hour infusion, and it should cover this period with mesna. If you want to go to an oral mesna, which might be more convenient for an outpatient clinic or for reliable patients, for the patients who are very well hydrated, who don't have nausea, you should give always the first dose IV at baseline and the other 2 doses orally, but as you can see, double the dose because of the bioavailability. So it's the same time, 4 and 8 hours, but with the oral administration, you should give 40% so that you have a total of 100%. And remember that also ifosfamide has some kidney toxicity, and therefore be careful when you use it in schedules like the BIP or the TIP, which are used for testicular cancer, because it's given in combination with cisplatin. So keep some interval between the administration of cisplatin and ifosfamide to avoid to have the 2 drugs together at the same time in the kidney tubules.
It's interesting, Cristiana, you also mentioned methylene blue as an antidote for CNS tox.
Yeah.
I'm not sure if all institutions and hospitals use the methylene blue. I always thought it is not so widely used. We use it. There is a particular regimen. We give it 50 mg IV bolus and then 200 mg over 24 hours. But I think it's very specific and probably different in each institution. I'm not sure if everybody uses that.
Well,
but I think it's a respected antidote for CNS tox.
Yeah. So the point is that, Markus, thank you very much. That's very important because central neurotox is rare. But when you have it, it's really an emergency because the patients start to be very sleepy and with some confusion. And then there are hallucinations and the patients could become aggressive or very strange and the nurses and the other patients are scared and so on. So you should be aware that it could be something related to ifosfamide, and you should have always as antidote available the methylene blue. It happened to me, and it was really unbelievable, how the patient changed over 10 minutes. And the point is that this central neurotoxicity could be more frequent in the elderly, and also when you have a decreased creatinine clearance, but also when you give some neurotropic drugs. And neurotropic drugs are really a broad class. For example, benzodiazepine. You give some benzodiazepine sleeping pills, and during the night you are cold because the patients who receive hypo or who was on hypo continuous infusion started to go around with the hallucination and so on. So try to avoid to give concomitant neurotropic drugs when you give ifosfamide. And also be careful because that's, in my opinion, it's not an easy drug to handle with. Thank you very much, Markus, for this observation, which is important. This is for the triazenes. As I mentioned, they are the dacarbazine, which is given IV daily times 5. That's the classical schedule for malignant, was the classical schedule for malignant melanoma every 3 or every 4 weeks. There's a longer half-life, and there's a high degradation and extensive liver metabolism. The acute toxicity could be very severe in terms of nausea and vomiting, could be very troubling for patients. So it's important to give a very good antiemetic prophylaxis and also to explain to the patients that during the days of the treatment, the patient should be in a quiet place with not too much noises around, rumors, and perhaps be fasting during the day and have something very light at night, like nitrosurias, because you have an acute nausea and vomiting, but also some delayed. And all these toxicities are increased if there isn't a proper way of giving the drug. Also, there could be some toxicity related to sun exposure during the treatment, like a kind of hyperpigmentation on the skin, and also some hepatic toxicity as well as local in terms of phlebitis or pain in the vessel of administration. And temozolomide is given orally, and this is the typical schedules for a glioblastoma, daily times 5 every 4 weeks. There's a very good bioavailability. The half-life is shorter and it crosses the blood-brain barriers, and this is the reason of the activity in brain disease. And also, if you have toxicity, which is mostly thrombocytopenia, which could be also late, the dose should be decreased by 50% milligrams per meter squared daily. But it's important not to decrease under 100 milligrams daily, because at this point you can lose the anti-tumor effect. And also it's important to remember that there could be some delayed recovery, and so the treatment can be repeated every 4, but perhaps every 6 weeks. It's important to wait for the recovery, as I mentioned before, to avoid the accumulation of the toxicity. And these are the specific toxicities. we discussed already the secondary leukemia, which could happen with the chronic treatments as well with the high dose treatment, and these were the cases of secondary leukemia in breast cancer patients who received high dose treatment with adriamycin and cyclophosphamide in an NCI protocol. As well, they are reported with nitrosourea. So it's important not to give the treatment for a prolonged period of time, avoid the chronic maintenance, and for the high dose treatment, limit the number of cycles. As regards the allergic reaction, it could be some skin toxicity, which is not frequent, but you should be aware because sometimes patients come on treatment with cyclophosphamide, even with oral administration, with some cutaneous erythema. That could be related to cyclo. As well, you can have some facial rash, perhaps during the administration. And the other important toxicity is the immunosuppression. And it's important to remember it because patients who have received alkylating agents for a long period of time, they are immunosuppressed. And they could develop opportunistic infection. For example, the situation of the viral infections or pneumocystis carini in patients who received temozolomide for a long period of time. Okay, so I think that it's important if you ask the question or send messages to Markus for a point you want to discuss. And then let's go to the platinum agents. So I tried to summarize the key points which are important when we see the different specific compound. So the fraction ultrafilterable, so unbound to proteins, which is the active one. And perhaps, Markus, you want to comment on the value or, the particular PK value and the methods which should be used to assess the relevant concentration of platinum.
Yeah, as you mentioned, first of all, the platinum have a very short half-life, and the active compound is only this one that is not bound to intravasal proteins, so I think mostly albumin. So that's what we call the ultrafiltrable fraction. That's the unbound fraction.
Yes.
Although that's quite a general principle for drugs in general, that the active moiety usually is the unbound.
Yeah.
And there is quite a lot of discussion in the literature about the importance of the bound to unbound fraction. For example, there are certain conditions where the bound fraction unbound, the ratio can change. For example, in patients that with cachexia that have hypoproteinuria, hypoalbuminemia.
Yeah.
So, but the clinical relevance of those situations, in my opinion, is not that clear. But in any case, the active moiety is the unbound.
Right. And the point is that the platinum agents, they stay for a long time in the tissues. Cisplatin is really unstable in the aqueous solutions, and once it's within the cells, the chloride leaving groups, which is, it's a very easy, very simple structure. It's almost unbelievable how active it could be with this kind of structure. So there are the chloride leaving groups, which leaves and are replaced or binds to DNA once the compound is in the cells. But the point is that carboplatin, because of the different structure, because of the different leaving groups, which is the cyclobutane decarboxylate platinum, is completely different, is more stable, there's a longer half-life, stays in the tissues as well, and it's eliminated by the kidney by only the glomerular filtration process. And this is one important thing, why there's some kidney toxicity related to cisplatin, and why carboplatin dose can be calculated with the Calvert formula, because there's only one process at the level of the kidney excretion.
It's amazing how long platinum drugs can stay in the body. They really have very strong covalent binding to tissue. So you can really, with sensitive methods, you can measure platinum decennia after administration of platinum drugs.
Yeah. No, that's I think a fascinating class of agents, because that's a very simple structure. Working on the molecules, you can induce completely different activity, toxicity, pharmacokinetics, and they bound to tissues, and they are very effective. They are among the most effective drugs. So that I think that they are still a class of drugs worthwhile knowing and using. So these are the three ones you should know how to handle with. The first one is cisplatin. This is the classical schedules of treatment. It can be given every 2 weeks because there are almost no myelotoxicity. So that can be used in combination with myelotoxic agents. The majority is excreted in the kidney. So it's important to look at the kidney function, and it's excreted 25% in 24 hours. Carboplatin, this is the living moiety, the decarboxylate, cyclobutan decarboxylate. This is the schedules and the Calvert formula. So you can see there's a longer half-life, while the beta half-life is almost the same. And it's a very stable compound. So it's not so reactive as cisplatin. And this is oxaliplatin. You can see an increase of the moieties linked. This is the schedules 85, 100. This is for the combination every 2 weeks. And again, the renal excretion is less important than with cisplatin. So oxaliplatin is a compound which can be used in case of some mild renal impairment. So that's important to remember, because it could be a good substitute for a particular situation of cisplatin. And these are the toxicity. So the point is that with cisplatin, if you have a bad renal function, you should replace with carboplatin. And the well-known acute toxicity on which the most powerful antiemetics today were developed. There could be some electrolytes imbalance because of the damage to the kidney tubules, and there could be some dose-dependent ototoxicity. So it's important to check it regularly. For example, when you use it for the management of testicular cancer in young men, it's important to remember the ototoxicity could be very cumbersome and could be irreversible. And the ototoxicity is dose-related, while the kidney toxicity is also acute, but it could be also cumulative. So remember, when you give later on a potentially nephrotoxic drug in a patient who received already cisplatin, remember that even though the creatinine clearance is normal, there's anyway some subclinical damage. So it's important to pay attention. There's a peripheral neuropathy, which is accumulative, and the myelosuppression is almost absent. There's only anemia. While if you go to carboplatin, you could see that and you are aware that the nausea and vomiting, there's no acute, but there could be some delayed nausea and vomiting. So it's important to cover and to adapt accordingly the antiemetic prophylaxis. The peripheral neuropathy is lower, is cumulative, but is less extensive than with cisplatin, and the problem is myelosuppression. So the point is that it's not good to be combined, for example, with radiotherapy as cisplatin, because you increase the myelosuppression. And very often when you have the schedules of a combination with the cisplatin, with radiotherapy as radiosensitizer, the main treatment is radiotherapy. And you shouldn't jeopardize radiotherapy because of the platinum agents combined. So with radiotherapy, always use cisplatin because it doesn't induce myelosuppression. In addition, with carboplatin, you have usually the platelets decrease around day 15, 18 with recovery in 3 weeks. But it could be that the recovery takes longer. Wait for that. Wait up to 4 weeks because otherwise you can have accumulation. And then remember the hypersensitivity reaction. The hypersensitivity is also related to the duration of treatment and to the cumulative dose. That's more frequent in patients who received already carboplatin. And remember that there's no, in the majority of the cases, cross-reactivity with cisplatin and oxaliplatin, because that's related to the structure of the cyclobutane decarboxylate. So the point is that patient says responding to treatment with carboplatin, there's a hypersensitivity reaction, which might be mild the first time, which might be more severe the subsequent time. You can switch the patient to cisplatin or to oxaliplatin. Keep oxaliplatin as the latest one in the sequence because of the myelotoxicity. And what is characteristic of oxaliplatin is that you have accumulation of peripheral neuropathy, which is on a greater extent than the previous one, and which is very burdening and burdensome for the patient, and you have thrombocytopenia. And the point is that once you have thrombocytopenia with oxaliplatin, you are stuck there. Because until you have neutropenia, you can use the growth factor. Once you have thrombocytopenia, you are stuck. So keep it as a last of the sequence. So if you have questions related to this class of compounds which are very broadly used, please send it to Markus. How much time do we still have? Well,
I think we were supposed to finish within 5 or 10 minutes.
Okay. So quickly, the antimetabolites. I think what is important to remember is that there are 3 groups: the antifolate with methotrexate and pemetrexate, the pyrimidine analogs, which are 5-FU, capecitabine, and gemcitabine in solid tumors. And the purine analogs are mostly used in lymphoma, so I'm not going to revise that. So that's, I prepared some slides. You can go to later on. What is important for methotrexate is that to remember that methotrexate is an inhibitor of the hydrofolate reductase, which is the enzyme responsible for the reduction from the hydrofolates to the tetrahydrofolates, which are important for the purine synthesis. And I think this figure is quite nice because it shows which is the rescue effect of leucovorin, because it replenishes the pool of the tetrahydrofolate, which has been decreased by the inhibition on the EHFR. But also what is important is the polyglutamylation process, because once methotrexate is glutamate, is in the form of glutamate, cannot be kicked out from the cell. It stays in the cell, which is one of the mechanisms of resistance. And also the glutamation is important for the effect on the thymidylate synthetase. And that's important and for example, later on when we are going to use the combination with leucovorin for some other compound. So, These are the different processes in which methotrexate is involved. This is the system. And here you can see where leucovorin is active, and this is the main enzymes which is inhibited by methotrexate. This is the structure, and you can see that it's an analog of a natural compound, and that's related to this particular substitution, and this is the mechanism of the polyglutamation. And then what I wanted to show you is the Alimta, which is the Pemetrexed, and Alimta was developed as a compound which could be active in case of methotrexate resistance because it acts on 3 different enzymes. And actually, Pemetrexed inhibits again the hydrofolate reductase, but also has an inhibitory effect on the thymidylate synthetase, where also 5-FU is active, but also is active on a 3rd enzyme, which is called the GRFT, which is important for the de novo synthesis of the purine nucleotides and thymidine. Now, when the Pemetrexed was developed, the initial problems were the problems of the kidney toxicity. The first compound was called the Pemetrexed. And then it was realized that the kidney toxicity could be solved by an adequate hydration because there was the renal excretion. But there was also the point of the very severe mucositis. And later on it was realized that the mucositis was related to a depletion of the folate. And then in humans, sometimes the folate pool is not very high. And that's the reason why it's important to start with the supplement 1 week before the treatment. So we should have an adequate folate pool, and that's done by giving folic acid starting 1 week before the treatment once a day, and the other one by adding vitamin B12, because when we have the the lack of these 2 natural compounds, we have the classical folate depletion, folate toxicity, which is the mucositis, which is the glossitis, and which is the skin toxicity. Then the last point, which is very highly recommended, is the use of steroids to ameliorate the skin rash. So that's also important to start with the pre-medication 1 day before the treatment. So that's part of the regimen for using Pemetrexed in a safe way. These are the characteristics of the toxicity that's important in the kidney excretion. The myelosuppression, we can have the hand-foot syndrome, the diarrhea, and fatigue, mostly fatigue, possibly due to some central neurotoxicity. Now, I think that we can stop here to have questions. In the last slides, you'll find 5-FU and Capecitabine. Capecitabine is an oral prodrug of 5-FU, and 5-FU is mostly acting on the thymidylate synthetase, which is important, and the combination with leucovorin increase the binding of 5-FU to thymidylate synthetase, or it could act by incorporation into DNA. One common point of discussion is this one, the DPD deficit. I don't know, Markus, if you want to comment on that, which is the clinical implication of the
DPD deficiency.
Yeah.
Yeah, there is about 5% of Caucasians that are DPD deficient. We know that very well. It's also known that the genetic traits are quite well known. You can measure this in blood leukocytes, lymphocytes. It is not widely done.
Yeah, and
there is quite good data. And there is even an understanding that you should reduce the dose in those sensitive patients by roughly 50%.
Right. So that are you doing routinely when you use 5-FU or not? Because
We're
that's
doing it in a
question.
sort of clinical trial, but yeah, there are not many institutions that do that. There are some institutions in France and the Netherlands that do that.
Yeah. But it's not clinical practice to do it routinely, I think.
Not yet, no.
But perhaps you can do it in case you have patients who develop higher than expected toxicity.
Yes, absolutely.
Hand and foot syndrome or some mucositis. And
yes, absolutely. So if you have patients that have severe toxicity and still are enthusiastic to go on with the treatment, there is certainly in each country there is a possibility to do this analysis. And so in this case you can explain to the patient, look, you have a genetic trait that makes you more sensitive to this drug, and we know it now, and we can reduce the dose and should be fine.
Right. Yeah. For example, some early severe hematological toxicity, which is not peculiar of 5-FU. So when you have something strange, unexpected, perhaps it could be worthwhile checking it. While when you have the clear syndrome, again, this is another quite impressive situation because the patient developed very rapidly central neurotoxicity, and so it's really important to stop the treatment, hospitalize the patients, hydrate the patients, and wait for the severe diarrhea. So and the severe myelosuppression, because at this point you should cover the potential infection at the bowel site.
Yeah, I maybe add a small point to Pemetrexed, which is quite an amazing drug, and given over very different dose ranges. You can give it a very high dose.
Yeah.
If you give it high dose, it's important, you mentioned it here, I think it's important to avoid giving it to patients that have pleural effusion or ascites, because you have this redistribution of the drug back into the system, and those patients can have very severe toxicity. And the other thing is that in rheumatology, Pemetrexed is also used as immunosuppressive drug given orally. Usually they give it once a week, and you know that very well. From time to time you have those accidents, those unfortunate cases where the patient takes the drug maybe daily, or even thinks he has to use it as an analgesic drug and takes it more often per day, and so these patients can then become intoxicated with and suffers cumulative Pemetrexed effects.
Yeah, it's very, that's a very important observation, because you can have also develop chronic hepatitis, and go into cirrhosis because of this repeated administration. Or you can have a renal failure related to this treatment because they could be elderly, they are not so much hydrated, and so on. And then you go into trouble once you start anti-tumor treatment in this patient. So that's important to be aware of. Yeah, thank you very much. So that's Markus. Did you receive questions?
No, I didn't receive questions so far. I checked regularly, but
does the system work? Because I think
so. Yeah, I think so.
Well, perhaps we can do in this way that perhaps if there are also questions coming later, we could ask Francesca to collect them and then to send them to us, so that we can reply even outside the session that it might be that there was not a possibility of somebody is going to look at the session later on. And if you have questions, please send them to Francesca, to Weso, so that we can answer to you. Are there other points, Markus, you want to raise?
I think that this was a very full summary of the alkylators and platinum compound.
Yeah. And the antimetabolites, I think you should know where they act and which are the main toxicities. The last comment, Markus, what about the new oral pyrimidines? S1, all this, there's a broad field of investigations, mostly in GI tumors. Do you have experience with them?
Yes, so S1 is quite broadly used now, at least, of course, it came from Asia.
Yeah.
Is the drug. It was developed by a Japanese company, I think, and is now quite broadly used in Europe. I'm not sure how broadly it is used in America, in the US, but as you stated, in gastrointestinal tumors, so in colorectal, also in gastric tumors, it is approved.
Yeah.
And quite widely used.
And
good tolerated overall. You don't have the issue of DPT deficiency.
Right. Okay.
Issues, so that's an advantage.
Okay. Yeah, but it's very expensive, I can imagine. And that's and I think it's easier to use, but I don't know really how much is better than, for example, Capecitabine and so on.
But S1 has never gone to earlier lines of treatment, so and still I think that they do not challenge and try to put it into combination regimen.
Okay, right.
So it's used as a monotherapy.
Okay, well, thank you very much. Well, I think that we can close the session if it's fine for you, Markus.
Yes.
And thank you very much for the ones who assisted to the session. And thank you very much, Markus, because you pick up a very important point. And I'd like to remind you this important appointment. Markus will give a lecture on the clinical pharmacology of targeted treatments next Thursday, same time, 31st October. Markus, do you want?
It's later. It's 6:15.
Right.
It's later in the evening.
Could you say what are you going to talk about?
Yeah, we will cover the importance group of targeted anti-cancer drugs, so mainly the tyrosine kinase inhibitors. We will briefly touch a little bit on PARP inhibitors, CDK,
Right.
and try to look at important aspects of this important group of drugs.
Well, that's very good because it's something we didn't cover so far in this pharmacology lesson. So it's a very important enrichment, I think, and it's a clinical practice because these are all compounds we used, and I think we are not so much aware of which are their characteristics, advantages, and how to use them. So thank you very much.
Right, thanks.
Thank you, Professor Sessa, and thank you, Dr. Jörger. Ladies and gentlemen, the session has now concluded. The next TSO session will take place on the 31st of October at 6 p.m. and Dr. Markus Jörger of the Cantonal Hospital, St.Gallen, Switzerland, will discuss with Dr. Alwin Haedema of the Netherlands Cancer Institute, Amsterdam, the Netherlands, the following topic: clinical pharmacology of targeted treatments. Thank you for participating, and have a pleasant evening, day, or night. Goodbye.